Very good evening, one and all. I am Arpita from the IGCP group. The topic that we are going to discuss today is diabetic retinopathy. Diabetic retinopathy remains a leading cause of vision loss among individuals with diabetes. This webinar will provide a comprehensive overview of this condition, focusing on early detection, prevention strategies, and the latest advancement in treatment. And yes, to address this topic, we have with us someone very eminent from the field of ophthalmology, none other than Dr. Pravan Gupta, sir. It's an honor for me to welcome sir to this platform and to introduce him to everyone. Sir has done MS in ophthalmology. He is a senior vitreoretina specialist at I7 Chaudhary Eye Center, which is at Lajpat Nagar, Delhi. So, with this very brief introduction of sir, I would now request him to please start with the topic for today. Over to you, sir.
Hello, welcome everybody. Good evening. So, I am Dr. Pavan Gupta. So, today we will be discussing a very important topic, diabetic retinopathy. And as I was told that it is mainly for our physicians and senior specialists who are treating who are treating diabetic patients. So, I have kept this presentation very simple so that it is easy to understand, and we will be covering few basic aspects of diabetic retinopathy and what are the investigations and treatment options that are available in today's scenario. So what basically diabetic retinopathy means? So diabetic retinopathy is a condition where high blood glucose level leads to changes in the retinal blood vessel. That is, this disease mainly affects our blood vessels of the retina. And these retinal blood vessel changes lead to series of changes in retina which lead to vision loss. And if not treated properly, it can in some cases lead to complete blindness also. And it can happen in both type 1 and type 2 diabetes. So let us look at what basically this diabetes do to our microvascular blood vessels in the retina. So it begins with damaging the pericytes. The pericytes are the lining of the blood vessels which are responsible for maintaining the barrier of the blood vessel. And once these pericytes are damaged, it leads to microocclusion. And once these blood vessels are occluded, it causes retinal ischemia. And once retinal ischemia happens, body or the retina gives a signal that there is no oxygenation available to the retina, and in response to this hypoxic signal, our retina starts producing a hormone called as VEGF, vascular endothelial growth factor. And this vascular endothelial growth factor lead to series of changes like AV shunt formation, new blood vessel formation. And when these new blood vessel formation happen, in some cases it lead to fibrous tissue proliferation. So now, as I was talking earlier, this loss of pericyte disturbs the barrier of the blood vessels, which lead to microvascular leakage. And once this leakage starts from the blood vessels of the retina, this fluid or the retinal this fluid starts accumulating in the retina, and we call this as an entity called as retinal edema. And as in the previous slide, we have seen that in some cases, because of occlusion of blood vessels, these new blood vessel formation happens, and these blood vessels are very fragile and they have a tendency to rupture. And when these blood vessels rupture, it leads to hemorrhage in the eye or the blood in the eye. And this retinal edema is accompanied by hard exudate, or these are basically cholesterol or the lipid exudation, and localized edema. Wherever there is leakage from the blood vessel, this edema happens. And if there is profuse leakage, if the blood sugar levels are pretty high and the control is not good, and there is advanced diabetic retinopathy, then practically every part of the retina start leaking fluid, and this we call this as diffuse macular edema. So, what are the risk factor which precipitates this changes in the retina or which leads to diabetic retinopathy? The most important factor is duration of diabetes. That means as the duration of diabetes progresses, the chances of a person or a patient getting these diabetic changes also increases. Another factor is poor blood sugar control. If your blood sugar level of the patient is not controlled, then there are high chances that these patients will get high diabetic retinopathy, and which is pretty aggressive in nature. Along with the blood sugar level control, other systemic factors like hypertension, hyperlipidemia, and even if patient is not taking proper care of the physician, sometimes physicians are not available to the uh, patient, or they are not following the advice of the physician to take care of their blood sugar level. All these cases have a tendency where these diabetic retinopathy changes come early. Now, as I have told that duration of diabetes is the most important factor, so we have seen that after 20 years of diabetes, nearly practically every patient of diabetic retinopathy with type 1 will get some changes. And 60 to 70% of the patient with type 2 diabetes will have some degree of diabetic retinopathy. How advanced or how aggressive the diabetic retinopathy is will depend on how the patient has maintained or controlled his blood sugar level over these years. So now, what are the signs? I mean, how do we identify and that patient is having diabetic retinopathy? So the very initial sign of diabetic retinopathy is microaneurysm. Now, these microaneurysms are basically very small outpouchings or grape-like outpouching in the retinal blood vessel. Along with this, in initial stages, we have dot blot hemorrhages, retinal hemorrhages, or sometimes they are flame-shaped hemorrhages, cotton wool spot, hard exudates or lipid exudates. I will be showing with examples how these findings look on the retina. And we have macular edema. And if disease is still get further advanced, then there is looping or venous beading. And at last, there is new blood vessel formation. And in some cases, this new blood vessel formation, they have a tendency to bleed, and this causes vitreous hemorrhage. So the important is that when patient present to us for the checkup of their status of diabetic retinopathy, so we classify the disease accordingly, that in what stage this diabetic retinopathy is. And this is important because the follow up protocol and the treatment depends on how, on which category or how advanced the disease is. So we basically categorize diabetic retinopathy into four types. One is mild diabetic retinopathy, moderate, severe, non-proliferative diabetic retinopathy, and at the end is a proliferative diabetic retinopathy. The difference between the proliferative and non-proliferative is that in non-proliferative there is no new blood vessel formation. That means the chances or the tendency of a patient to have a bleeding in the eye is very less. But in proliferative diabetic retinopathy, the chances of bleeding are pretty high. So now this is an example of mild non-proliferative diabetic retinopathy. I mean, you can see these are small red dots. You can see these are few microaneurysm, and you need a very careful clinical examination to pick these findings at this stage. But as the disease progresses, I mean, you can see there are the hemorrhages and these microaneurysms increase in number, and these yellow crystals which you are seeing, these are hard exudate or these are lipid exudates or cholesterols which comes out because of leaky blood vessels. This is moderate NPDR. And if disease progresses further, I mean, you can see the difference how many hemorrhages, these blood spots are there on the retina, and lipid exudation is also quite a much. So at this stage, we classify this disease as severe non-proliferative diabetic retinopathy. And after this stage, even if patient doesn't take care of himself, then the disease progresses to advanced stage, and here the venous looping happens. You can clearly see that how the retinal blood vessel changes. I mean, they loop in response to the hypoxic uh, stimulus. And this is the last stage where the neovascularization of the retina happens. And sometimes, as you can see here, there is a bleeding happening over the retina. At this stage, patient will complain of sudden loss of vision because this has totally hampered the macular area, and patient will complain that I am not able to see anything. And this usually patient complains of that this happens all of a sudden. So another important thing that we discuss is, apart from this staging, is the macular edema. Now here we can see that this is the normal OCT or picture, that this is how our normal retina looks like. But in diabetic patient, you can see this is how this fluid accumulation happens in different layers of retina, and it causes edema. So, diabetic edema in diabetic retinopathy is the major cause of decrease in vision or blindness, or patient finding difficulty in managing their day-to-day activity. In majority of cases, the disease begins with diabetic macular edema, and later on it progresses to the proliferative part. So, another entity is when to treat. So this macular edema can happen to many patients, but the important question is that when these patients need treatment. So there is an entity called as clinically significant macular edema. In this, as you can see in, just wait. As you can see in this picture, these yellow spots which you are seeing, these are hard exudates or lipid exudation, and this is our fovea. The central layer where my the cursor is, this is our fovea. This is the fine area from where which we see and everything. This is the most important area of the retina. So according to the classification, when these hard exudates or these lipid accumulation happens in this foveal area, so this we classify as macular clinically significant macular edema. And it is usually when it happens within 500 micrometers of the center of the fovea, then we say that this is the clinically significant macular edema and patient needs treatment for it. So this is the theoretical part. Now the important is that how do patient complain? I mean, so many our physicians friends are dealing with so many diabetic patient day in and out. So how these patients usually complain at first is that they will complain of blurred vision, and sometimes the bleeding happens, or they complains of floater and flashes. And if there is lot of macular edema, these patient complains of distorted vision. And sometimes they complain of black patch. If there is a blood in the center of the eye, then these patients will complain of something black shadow in front of their eye. They will have poor vision in the night, and their contrast sensitivity will also be decreased. So now, once these patients are referred or they come on their own to an eye specialist, what is the protocol for examination? How do we go ahead with when patient present to us? First, obviously, is history taking, and for how long these patients are taking their medication for diabetes, whether their diabetes is controlled or not. But focusing on typical on the diabetic retinopathy part or on the eye part, the first thing is that we examine the patient, we check their visual acuity, their eye pressure, their glass number, and undilated examination. Undilated examination is important in these patients is because sometimes these new blood vessels, they grow over iris also, and we need to examine whether these blood vessels are there on the iris or not. Because if these blood vessels are there on the iris, this is a pretty advanced stage, and we need to treat these patients pretty aggressively. And once we have done this basic examination, then we need to dilate. uh, so this is how we need to dilate the pupil, and then just so we need to dilate the pupil, and there we see the retinal changes. So this is, we dilate the pupil with the help of few eye drops, and this is how our retina looks. This is the optic nerve in the center which connects our eye to the brain. This is the fovea or the macula, the central area, and this is the initial stages. This is how these diabetic changes look in the initial, and as the disease progresses, these blood vessels and these hemorrhages, they keep on progressing, and at the end we see neovascularization. So this is just a cartoon type of a picture that I am just I have shown so that it is easy to understand that how these retina looks and how these changes happen over time period. So once we have examined and we have classified the patient in which category it lies, the another important thing is next step is to investigate the patient from systemic point of view, and these are few investigations that we advise to our patients. And if this then patient is uncontrolled, then we ask them to meet their physician or diabetic specialist to control their basic parameters, which are very helpful in managing diabetic retinopathy. It is not only the eye treatment which is required, it is the holistic approach. We need to take care of our body in total, and here we take help of our physician friends to control all these parameters. Now coming to the ocular investigation, the eye investigation which we do, the first one and the most important is fundus fluorescein angiography. Fundus fluorescein angiography basically gives us an idea about the vasculature of the eye, that how are the retinal vessels are behaving. So this is how this test is done. Basically, we these are the changes that happens in the retina, and we usually advise our patient to do an angiogram. So this is a very simple investigation. A dye is injected in the arm, and through that arm, through the circulatory system, this dye reaches the retina, and this is the setup where we click some pictures of the eye, and this is how once we have injected the dye, this is how our retina looks on uh, on the angiogram, and we can study the various phases of the uh, retinal blood vessels. So this is another investigation which is important is optical coherence tomography. This is also a very simple investigation, and this investigation we usually do to study the structure of the retina. Basically, the second important parameter which we are looking in diabetic retinopathy is the amount of macular edema is there. Now we have tools where we can exactly measure the retinal edema, and accordingly we can treat and measure the response. So this is also a very simple investigation, and this is non-invasive. We don't need to inject any dye or anything. This is how it is done. Patient is sitting on a chair, and this is just it, on a screen we get different layers of the retina, and which we can later on quantify that how much macular edema is there. So this investigation is also helpful in follow-up visits. That means that suppose on a when patient comes to us on first visit, we did all this investigation and there is no major changes in the retina because of diabetic retinopathy. And on subsequent follow-ups, we can do OCT, as this investigation is non-invasive. We don't need to inject anything. This is simple and this doesn't emit any rays or anything. So this is practically an harmless investigation, and we can repeat this as many times as we want. So as in this case, we can see that initially the macular edema was not there. This is the normal scan, and as gradually we keep patient on follow-up, the edema tends to develop. So this is the stage where we would like to start the treatment. So OCT is a very important investigation in management of diabetic retinopathy. So again, this is to measure the response of the treatment. Also, this investigation is helpful. Now, as in this patient, this is presenting with massive macular edema, and once we start him on the treatment, we can on subsequent follow up we can follow that how this patient is responding to our treatment, and as we can see that after a month of our treatment, this macular edema has gone away, and patient is showing response to our treatment. And on some cases, if we see that patient is not responding well to whatever treatment we are giving, we can change our treatment plan. So now coming to what are the treatment options. So now the first line of treatment in today's scenario is intravitreal injection. As initially I have told you that major the changes that happen in retina is mainly because of this vascular endothelial growth hormone. So there are injections that are available today, which we called as anti-VEGF injections, and these are available in biosimilar as well as different brand names, and they have some peculiar abilities which I am not discussing now as it would get too technical. But these injections, the point that we need to remember is that if effect of each injection is maybe 4 to 6 weeks or 2 months, so these injections we need to give on repetitive basis, and we need to educate our patient that you need to take these injection on regular basis. Once the effect of your previous injection goes away and your macular edema or the disease activity comes up again, then we need to inject again, because patients sometimes get fed up by getting these repeated injections. So first is anti-VEGF injection, and second is a steroid implant which is available in form of Ozurdex implant. Uh, this is very important as this steroid implant is slightly longer acting. In it functions or it works for roughly 3 months, and we can repeat maybe 2 times or 3 times in a year. The only thing that we need to keep in steroid implant is that in some patient it can lead to eye pressure rise or cataract formation. So we need to tell our patients and choose the injection according to the need of the patient, that whatever best suits the patient. So this is how I have just given. This is how the injection are given. It is a very simple procedure. A small needle, a 30 gauge needle is we use, and we enter through white of the eye, and we give 0.01 ml, a very small, maybe 2 or 3 drops of the drug is injected inside the eye. This is just graphics how it is given, and this is I am just showing you the actual video of a patient. This is very thin 30 gauge needle, and this is how we give. This is an anti-VEGF injection that we have injected, and but the procedure is done. The second is how to give uh, the steroid implant. So this is again, so we measure at a particular distance, and this is how this is the needle. This is a 22 gauge needle, and this is we just give the injection, and we so it hardly takes maybe 30 seconds to 1 minute, and it is a painless procedure. We anesthetize the eye with topical eye drop before giving these either steroid implant or anti-VEGF injections. So another important aspect while treating these patient is laser photocoagulation. Sometimes patients get fed up, or they are coming from far off areas and they cannot take regular injections. So in such cases, there is another option which is called as laser. So laser basically are we depending on which area we are doing is focal laser, where we target each microaneurysm, and grid laser when there is a diffuse area of leakage. So when we do this, this is and pan-retinal photocoagulation. Pan-retinal photocoagulation we do when uh, disease is pretty advanced. It is a proliferative diabetic retinopathy. So we complete this pan-retinal photocoagulation in 3 sittings or 4 sittings, depending on patient to patient. And this is I'm just showing how simple it is. This is how the laser is done. This is an OPD procedure. There is no incision, nothing. So we place this lens inside the eye just to focus the laser beam wherever we want, and this is how we do the retinal laser. So another treatment option is surgery. Now once patient has reached pretty advanced stage, there is blood inside the eye which is not going away with injections and laser. This entity we called as non-resolving vitreous hemorrhage, or there is traction in the retina. I mean, there is pull in the retina, or retina has detached from its place. I mean, which we called as combined retinal detachment. In these cases, these injections and laser doesn't help, and we need to do retinal surgery. And the surgery which we do is pars plana vitrectomy. And this surgery these days we are doing is pretty simple by three endoscopic port, which are 25 or 23 gauge, and we clear the blood. This is how the surgery is performed. So we make three ports. One port is to give fluid, and this is the cutter which we are using to clear the blood. And this is the source of light. This is the inside, and as you can see, and gradually with we are clearing the blood. I mean, pars plana vitrectomy, when we do it, roughly takes 1.5 hour time of surgery, and visual recovery is not all of a sudden. It usually takes 2 to 3 weeks for vision to recover. But this is a good option, and in some cases where our injections and lasers don't work, I mean, we can help our patient with the help of this pars plana vitrectomy. So now, last and most important is what should be the protocol for examination of our patient once our physicians or physician or diabetic specialist have asked their patient to go for a retinopathy checkup. So what should be the protocol? So first examination in case of type 2 diabetic retinopathy should be immediate whenever a physician diagnosed a patient with diabetic retinopathy. So first examination should be immediate in type 2 diabetes. In type 1 diabetes, I mean, it can be 2 to 3 years from the date of diagnosis, but usually we advise that it is better in both, in cases of type 1 and type 2, that one retinal examination should be done at the type of examination. So once we examine and patient doesn't have any diabetic retinopathy, then annual examination is good enough once in a year. If mild retinopathy, non-proliferative diabetic retinopathy is there, that there are only few changes like microaneurysm, then every 6 month or examination is good enough. If diabetic retinopathy is slightly progressed, then every 3 to 6 months. And if it is severe proliferative diabetic retinopathy, then probably every 3 months or maybe even less. Proliferative diabetic retinopathy, we need to see our patient every 1 to 2 months, because these patients progress very fast, and we need to be pretty aggressive with our treatment for initial 3 to 6 months. So proliferative diabetic retinopathy patient needs frequent follow-ups. And in case of diabetic macular edema, it all depends on the follow-up. So usually what we follow is that if diabetic macular edema is vision threatening, if it is compromising the patient's vision, then we follow this patient every month. And whenever there is need of either injection or laser, we advise our patient that treatment. And if the diabetic macular edema is there but it is not vision threatening, then we advise our patient every 2 to 3 months follow up. And as on subsequent follow up, whatever the condition of the patient is, accordingly we advise our patient to come again. So this is all from my side. Hope this presentation will help our physician and diabetic specialist in advising and guiding their uh, patients regarding the health of their eye and retina in particular, because diabetic physicians and diabetic specialists have a long term bonding with their patient, because they are treating their patient for so long. So they are much more convinced when physicians tell them to go for their eye checkup, even if they are not having any problem. Thank you.
Thank you, sir. Thank you so much for such a beautiful presentation, I would say, and the visual representations, like the videos that you have shown, they are really very helpful to all the viewers. So, moving on to the questions, with your permission.
Yeah, yeah, we can go ahead with the questions.
Yes, sir. The first question is, how can patients with diabetes effectively prevent or delay the onset of diabetic retinopathy through lifestyle modification? or a medical intervention?
See, as I have told earlier, that main thing in diabetic patient management or diabetic retinopathy management is to control their blood sugar levels. And once they have controlled blood sugar levels, the another parameter is their hypertension. They need to control, and any other disease which they are suffering from. As we have seen, that patient with diabetic retinopathy, if have an infective focus, if they have a diabetic foot, their retinopathy also has a tendency to progress very faster. So when patient is diagnosed with diabetes, they need to follow the advice of their physician, whatever diet, and their dietitian, whatever their dietitian have told them, what to eat, what not to eat, and what quantities and what calories. So they need to strictly follow their advice for the long term health. Initially patient don't have any complaint and they take the disease very lightly, but once this disease starts affecting, then it's get too late. So my advice to patient is that they need to take care it. Once they are diagnosed, from the day one they need to be very very careful with their diabetes status.
Right, sir. Thank you so much for answering this query. Next question is, what are the latest advancements in management and treatment of diabetic retinopathy, particularly for advanced stage?
See, today, as I have told, diabetic retinopathy, the mainstay of treatment is injections, intravitreal injections, which these patients require on regular basis, and sometime it can be every month or maybe every 2 or 3 months, depending on what stage the patient is. Second treatment option is laser. So if the disease is pretty advanced and patient is having proliferative diabetic retinopathy, then laser helps us in stabilizing the diabetic retinopathy. Regarding the latest management is in the surgery. Initially, the results of surgery were not good, but in today's scenario where we are doing 23 and 25 gauge, and latest we have started is the bimanual surgery. So, I mean, the results of surgery are really good these days. But again, patient should not be in a mood that latest treatment is available and everything can be reversed. I mean, diabetic is a disease that when it progresses, we are trying to stop the progression of the disease by whatever way we are treating our patient. So patients need to understand that this we cannot reverse whatever changes have happened. So they need to be careful. So bimanual vitrectomy is the latest addition to present scenario where I mean the outcome of surgery have really improved with this technique.
Right, sir. Thank you so much for this valuable information. Moving on to the last question of this session. That is, how is artificial intelligence and imaging technology contributing to the diagnosis and monitoring of diabetes retinopathy in clinical practice?
See, we have done a project, I mean, 2, 3 years back, where this we were trying to assess the usefulness of artificial intelligence in diagnosing the patients of diabetic retinopathy. So basically, how it goes is that we take an picture of retina. I mean, it is a simple. You have a fundus camera and you take the picture, and where this fundus photograph capture all these minute changes what are happening in the retina and the retinal blood vessels. And now this photograph is sent to the artificial intelligence, and accordingly it classifies the patient in mild, moderate, severe category. But we initially found that classifying a patient is not very helpful. So what we did is that we need to know which patient needs to be treated and which patient don't need any treatment, or they can be simply kept on follow up. So we followed a protocol where we called as that patient which patients need referral. Okay, so now what we are trying to do is that with the help of artificial intelligence and that fundus photograph which we are taking, we need to classify these patients into simple basic two category: patient needing referral and advanced treatment, and patient just needing a follow up and good systemic control. So this is very helpful, especially in remote areas where access to uh, uh, advanced treatment is not there. So this fundus camera can take a photograph, analyze it through artificial intelligence, and if your artificial intelligence shows that this patient need a referral, the image is sent to the higher center, to the specialist doctor to analyze, and if patient needs treatment, patient is advised to come to the higher referral center for further treatment.
Right, sir. Sir, there are no more queries for today, so we would like to conclude it. But before that, I would like to thank you for sharing your valuable insights on this very important topic, diabetic retinopathy. And sir, your expertise and guidance were immensely appreciated and immensely helpful for all those who have attended the session. So, sir, with that, we would like to conclude. And yes, before that, I would also like to thank all the audiences who have joined in and for putting up their valuable questions. So thank you so much. Thank you once again to all.
Thank you.
With
Thank
that,
you.
we are wrapping up for today. Thank you, sir. Thank you so
Okay.
much.